antigen on the virus, and it's binding to the ACE2 receptor. And when we talk about anti-SARS-CoV-2 antibody detection, most of the assays that are available in the market now, they detect anti-SARS-CoV-2 IgG or IgM or their combination, but those antibodies, they are directed against the N antigen. And we have to bear in mind that those results that detects antibodies directed against the N antigen, those antibodies, they are non-protective. Those antibodies, they have nothing to do with immunity. Those antibodies, they can reflect exposure. They can reflect that the body has seen the virus and produced the antibodies in response to the virus. But they have nothing to do with production of, they have nothing to do with protection against the virus. When do we expect development of anti-SARS-CoV-2 antibody response after an infection? Usually in patients that they have developed the infection and the duration of the infection is between 0 to 6 days, usually 60 to 70% of them, they are positive for anti-SARS-CoV-2 antibodies. But at day 7 to day 13 after the infection, usually 80 to 85, they test positive for those antibodies. And after 14 days after the infection, usually 98 to 99% are positive for the antibodies. And after 16 days, and there are some publications that they say after the 3rd week or after 21 days, almost 100% of those who were infected, they develop antibodies. And we have to be very careful all the time when we talk about antibodies directed against SARS-CoV-2, and we have to distinguish between antibodies that reflects exposure versus those that can reflect immunity to the virus. And I have precautions that I have to mention here, because these days people, they take the result for the antibodies and they say that, do I have an infection? And some of them, they shelter themselves in their rooms because they tested positive for those antibodies. Anti-SARS-CoV-2 antibody testing should not be used for diagnosis of COVID-19. And presence of anti-SARS-CoV-2 can reflect exposure to the virus. And their presence does not reflect immunity. And presence of anti-SARS-CoV-2 antibody can be used, as Dr. Leila said, in surveillance programs to assess the magnitude of the disease in the community. And we have a definition for those antibodies that can correlate with immunity. There is a definition for antibodies that can correlate with immunity against SARS-CoV-2. And antibodies that are directed against the receptor binding domain of the S antigen, which is responsible for infection, those antibodies, they confer immunity. And because those antibodies, they bind to the S antigen and they prevent the virus from entering the cell. They interfere with the virus binding. And those antibodies that are directed against the S spike antigen, they have neutralizing capacity. And all the time we have to assess the neutralization capacity of those antibodies by using different titrations, using specific assays that I'm going to mention in the next slide. And there are few tests, we have to be very careful. There are few tests in the market that are available that detects, and there is no antibody testing that can measure SARS-CoV-2 IgG antibodies directed against the S spike antigen. This means neutralizing antibodies. They are those antibodies that are directed against the receptor binding domain of the S spike antigen. And those antibodies, they are the antibodies that they might have the capacity to neutralize the virus. Those are the neutralizing antibodies. And there are two tests or assays that are used to assess the neutralizing capacity of antibodies. And the first, which is a bit difficult one, that requires special biosafety cabinets because they use live virus, and they called live virus neutralization assay. And there is another assay that is now most of the centers are using it. It is a pseudovirus neutralization assay that is based on luciferase luminescence testing in the lab. And those assays, they assess the inhibition of the viral entry into cells in presence of the antibodies, and usually we use different titers. And then let us say a few words about convalescent plasma. And over the years, and also during the SARS-CoV-1 and MERS, it has been shown that plasma from recovered patients can be used as a means of passive immunization to treat patients with severe COVID-19. And the convalescent plasma should be assessed all the time before use for patients for presence of neutralizing antibodies, which are in fact the antibodies, as I have mentioned, that are directed against the S antigen. And I have a precaution here about convalescent plasma, because till now, there is no proven therapies for prevention or treatment of COVID-19 respiratory disease. And convalescent plasma should not be used outside the context of clinical trials, although there is evidence from previous SARS-CoV epidemic that patients may benefit from convalescent plasma from recovered patients. And another point which is really very important. Recent data showed that high IgG antibodies directed against SARS-CoV-2 can be associated with a poor prognosis. It has been observed that patients during their stay in the ICU, they have very high IgG directed against SARS-CoV-2 as compared to those who are having mild disease or asymptomatic. And this, it has several explanations that I'm going to mention in the second slide. Neutralizing antibodies, as I have mentioned, the antibodies that are directed against the receptor binding domain of the S antigen, those antibodies, they can bind to the virus and they can inhibit viral entry. But non-neutralizing antibodies, especially antibodies directed against the N antigen, can facilitate the infection. And from previous SARS and dengue models, we learned that antibodies can induce antibody-dependent enhancement. And as you can see here in this figure, that if you have neutralizing antibodies, those neutralizing antibodies, usually they bind to the S antigen, and they preventing the virus from entering the cell or binding to the ACE2 receptor. But non-neutralizing antibodies, they are the antibodies that are directed against the N antigen. Those antibodies, they can be uptaken by monocytes and macrophages, which are inflammatory cells. And as a result of that, Those antibodies, they can facilitate viral entry into cells via antibodies and via certain receptors on monocytes, like the Fc gamma receptors, that they bind to the antibodies that has bound to the virus, resulting in release of several inflammatory cytokines that can contribute to the inflammatory response in the lungs and destruction of the lungs. Now I'm raising another question. What is the role of antibodies? Do they play a protective role? If antibodies can explain the whole story of protection against developing the disease COVID-19, why some patients that they have antibody deficiency, they get pneumonia, but they recovered from the infection? No problem, they don't die. There are 2 studies that they came recently where patients with X-linked A-gamma globulinemia, they develop pneumonia and they develop lung manifestations, but they recovered from the infection. And it's very interesting. If you can go and read this publication, it's really very interesting by Sorinia and others that was published 3 days ago. They evaluated in that study the outcomes of SARS-CoV-2 infection in patients with primary immunodeficiency. In fact, they studied 2 patients with antibody deficiency. The 2 patients were positive for SARS-CoV-2 infection, but they never required oxygen supplementation and they never developed severe disease. And the questions that we raised, do we need antibodies to prevent the infection? Yes, antibodies, they might prevent infection. But what about the role of other immune mediators? Because those patients, they don't have antibodies, but they were able to recover from the infection. This means there are other effectors, immune effectors, that were able to control the infection. And the other question that I'm asking, do antibodies are strictly required to overcome the disease? I will come to the next slide. When we talk about a viral infection, if you ask a very basic question to any immunologist to tell him that somebody got a viral infection, what are the most effectors in the immune system that can remove the virus? Of course, it is the cell-mediated immunity. The CD8 T cells, which are the cytotoxic T cells. The CD8 positive T cells, we call them the cytotoxic T cells, or CTLA. And for viral infections, you need CTLA response to clear the infected cells. We have to know that some patients who recovered from the infection failed to develop or mount any neutralizing antibody response. And why? Some patients, they develop the infection and they recover and they don't develop any neutralizing antibody, or they don't develop antibodies at all. Is it a factor in the body that has restricted the immune response, the humoral immune response, and no antibody production in those patients? Or otherwise, this is a viral infection. What about the role of cytotoxic T cells? Always we have to think out of the box. Since antibodies and protection against COVID-19, it is not limited to antibodies, and there are other mediators. We have to think about cytotoxic T response. A recent study by Long and others, which was in Nature Medicine, that they have showed that patients who were asymptomatic have low levels and short-lived anti-SARS-CoV-2 antibodies. And theoretically, someone who was able to control the infection and become asymptomatic, and he didn't develop severe disease, should have immunity directed against the virus that has prevented severe disease. And we ask another question. Is there a differential humoral versus cellular immunity against the virus? Some people, they develop a strong cellular immune response and they clear the infection or preventing infection, while others, they mount a strong immune response. They mount an antibody response and they kill the infection. This is a $1 million question that we have to solve. We have a strong evidence that cellular immunity, apart from antibodies, plays an important role in prevention or from developing severe disease. And patients with severe acute respiratory distress syndrome who are admitted to the ICU might have what we call the cytokine storm. They mount a very strong immune response. A cytokine storm, and the cytokine release, it is from cells. It was a cellular immune response. It was not an antibody response. And usually those patients that they mount a strong cellular immune response and cytokine storm, usually they benefit from biologicals that neutralizes the pro-inflammatory cytokines that are secreted from pro-inflammatory cells, like tocilizumab, which is an anti-IL-6 receptor, or anakinra, which is against the IL-1 receptor antagonist. This means for sure we have a strong cellular immune response in patients that they have severe disease. But the other question, what triggers the strong cellular immune response? Yes, it is the virus, but what component in the virus? Is it what we call some specific antigens that they act like mitogens? We don't know. And yes, we have the tool, how to assess cellular immunity to SARS-CoV-2. Yes, we have the tools. There are several assays that can assess interferon gamma secretion in response to the viral antigens. And now I come to the conclusion. The spike S antigen and the nucleocapsid antigens, there are two important immunogenic antigens on the surface of the virus. And antibodies directed against the receptor binding domain of the S spike antigen interfere with the virus binding to the host cell, or interfering with the binding of the host of the spike antigen to the ACE receptor on host cells. And antibodies directed against the S antigen are considered as virus neutralizing antibodies, and they might correlate with protection. And antibodies directed against the N antigen they are non-neutralizing antibodies. And theoretically, we should not correlate presence of those antibodies with immunity or protection against the virus. And unfortunately, detection of antibodies directed against the N antigen, they are the basis for the majority of the tests that are available in the market. And we should always interpret the results that we got. Somebody who is having antibodies directed against SARS, we have to know, is it directed against the S antigen or the N antigen? And there is a big difference between the two. And since COVID-19 it's a viral infection, it is expected that cellular immunity or cytotoxic T lymphocytes to play a role in protection against the virus, although there is no studies and there is no evidence at all to support their role. Thank you very much.
Dr. Jihad, thank you very much. Another excellent talk, very informative, very up to date. There's a few questions here, and I'm not sure what the audience is saying, or the question is referring to, but I'll read it out and we'll see if we can interpret it. It says, how long after recovery can it be extract plasma? So I'm assuming what they mean is that after recovery, how long after recovery do we have neutralizing antibodies which potentially could be used, say, for passive immunization? I'm assuming this is what the questioner meant.
Yeah, there are, if we talk about practicalities and what we do currently, what we are doing now, here there is some criteria. There is a criteria that includes that the patient should be at least, he has two tests for COVID-19, two tests, I mean for SARS-CoV-2 swabs. They do 2 swabs, and 2 swabs are negative, and a duration more than 21 days. And then the plasma, it will be assessed for presence of antibodies that are directed against the S antigen. And if it is detected, usually people, they use dilutions. We do dilution and we select the highest dilution, and the highest dilution should be tested. This plasma should be tested for neutralizing capacity on one of the 2 assays that I have to mention. And if they contain neutralizing antibodies, this plasma or this donor should be asked for it. Usually they are asked to donate plasma.
Another question, Dr. Jihad, is how can we confirm that infected person with COVID-19 becomes free of the virus and not infectious after 14 to 21 days having the infection? This is related to a similar question to, I think, the question that was asked to Dr. Layla. So can we really be sure that the person is not infectious, even though they've recovered from the disease and 2-3 weeks after recovery and discharge from the hospital?
The prerequisite for discharge from the hospital, Dr. Layla, is if she's not there, I can answer. As a prerequisite to discharge somebody from the hospital, he should have the swab, which is really negative, and there are other clinical parameters that are usually assessed. And usually if you have somebody, usually most of the patients that are admitted in the hospital, they are usually patients with severe disease. And usually there are several inflammatory markers that usually they are assessed in their blood, not including D-dimer and ESR and CRP and lymphocyte CBC count. And usually patients that they have severe disease, usually they have deep lymphopenia, and they have high D-dimer, CRP, and so on. And usually when the levels of the inflammatory cytokines, they go down, and they do the swab, and then it is negative for SARS-CoV-2, usually they release them. And this is a reassurance that they are free of the virus because of recovery, in fact.
Another related question.
Yeah, if I may,
yes.
just add, Dr. Khan, so Dr. is quite right. It's just that the regulation have changed lately. Before they used to have patients in the hospital until they are completely RT-PCR negative. Now, if the patients have minimal or no symptoms and they can self-isolate, actually discharge them home. And not, they can self-isolate in a protected way at the places.
Thank you, Dr. Layla. Another related question from the audience is that being an RNA virus and obviously having high rate of mutation, what is the chance that the person will have immunity, long-term immunity for second infection?
The story of the secondary infection or reinfection.
Reinfection, yeah.
And what we mean by reinfection, somebody who was for sure was positive and he recovered and they tested him again by swab and he was negative. And then after 2 months or 3 months, he came back again with some complaints and they assessed the swab and he's positive. There are 3 possibilities, not a third one. The first one, he was having a low viral load. When they did the swab, they were unable to detect the virus because it's very low copy numbers and accordingly below the sensitivity limits of the method that is used. This is number 1. Number 2, the patient, the antibody, the response that we are talking about, or the immunity that is directed against the virus is short-lived. And if this is true, this is a nightmare to everybody. Yeah. And the third one, the virus has mutated and the previous infection, it was a different strain, and the different strain, the body mounted a proper immune response to the previous strain, and the previous exposure to the virus in the previous time did not protect him with the new strain, which has different antigens, and it was not protective. And the 3 situations, the first one is a mild situation, and the other 2, they are nightmares to everybody. Nightmares. But there is no evidence at all that the 2 are happening because people are still running and studying the possibility of the 2.
Yeah, I mean, that would be, in fact, in terms of vaccine development, I mean, this would cause major problems if either the virus establishes some sort of latency and reactivates again, or if the virus mutates and we have a different strain of virus to which, like influenza, for example, then as far as the vaccine is concerned, that's going to be a real nightmare of a scenario. Can I just ask one related question, just something which I picked up during your talk? You talked about X-linked conditions in the kids. There was a report recently from South Africa where they were looking for COVID-19 in the context of HIV. Now, surprisingly, what they found was that HIV positive patients, irrespective of whether they were actually on antiretrovirals or not, what they were saying is that HIV patients, generally speaking, did not show a higher rate of either severity of the disease or infection compared with the other population. Would that then also fit in with the point that you raised with the X-linked kids?
It's a different story. The X-linked immunodeficiency, antibody deficiency, it's a different story because it's and the hypothesis for that, it's if you have antibody, if you don't have antibodies, you can get infected, but you cannot get severe disease. Because why you cannot get severe disease? Because you have other effectors like CD8 positive T cells and cytotoxic T cells that they can control the virus. This means antibodies in this context, either the antibodies, they are responsible for protecting you from getting the infection. They interfere with the virus not to bind and enter cells. Yeah. But in the HIV story, it's a bit complex because you have immunosuppression. Because you don't have CD4 positive T cells, you are immunosuppressed. And we have learned from several cases that we have here in the hospital now. Patients that are kidney transplanted patients that are on tacrolimus, which is an immunosuppressive drug, they don't get severe disease in general. Some of them, they get severe disease, we don't know. Might be they are not compliant with their medication, but they don't get severe disease because, as I have mentioned, that the virus, it induces a very strong immune response. And that immune response, it is a cellular immune response. And that cellular immune response, which is responsible for the cytokine storm and the release of the inflammatory cytokines, that they contribute to the severe lung pathology. That contributes to the severity and taking the patients to the ICU because of the lung destruction. But if you have somebody who is immune suppressed and he cannot mount a proper immune response, mount a strong cellular immune response, this means he is protected. And this is what I'm expecting now. HIV, it is expected not to get a severe disease, because they cannot mount a strong immune response that contributes to the pathology in the lungs. But the other question, the other part that you have said, they have less, if they have the same incidence in the community, no problem. But if they have less incidence of the disease, this should be studied. And I have no idea at all, and nobody can explain it. But it is well understood that they get a milder disease.
Excellent. Thank you very much. I think Dr. Froese, last question. I think we're running out of time. But Dr. Froese.
Dr. Jihad, my friend.
Hi.
In the HIV infected patients, if the patient is suffering from pneumocystis carinii, then there is lung infection. Then what happens in those patients? There is immune response.
We have a very strong evidence that patients that they go downhill and they deteriorate and get sepsis-like illness, they are those who are having secondary infections. If you have two patients, both of them they got lung infection, and both of them are severe infection. If you take a swab from the two of them, one of them, his swab, it's free of any bacterial infection, and the second one, you have gram-negative bacteria, or you have viruses or agar bacteria. The prognosis is very bad. Secondary infection, we call it co-infection, and super infections, they are very strong predictors of morbidity and mortality in patients with COVID-19, because they induce sepsis-like illness. And usually the patients, they go downhill very quickly.
Okay.
Co-infections are very serious, and they are poor predictors of poor prognosis.
There's lots of questions. There's another one in terms of the BCG correlation with the people who've been vaccinated with BCG. Are they protected with COVID?
There is a publication. The reports came that the people, those who were vaccinated with BCG, they have infection rate with COVID-19 less than those who were not, infected, and those who were not vaccinated with BCG.
The problem with many of these reports, Dr. Froese, the problem with this is that with COVID-19, I think in terms of publication, the field has just been totally inundated with in terms of the reports. We're getting thousands and thousands of reports coming out on the field. Trying to sieve out what is really, in terms of, especially if it's a controlled study, well studied, from the rest of the study, it's not that easy. So there are lots of reports coming out. Some are conflicting others. So it's at the moment it's somewhat unclear whether to what extent. I was wondering what Dr. Jihad had, what his opinion was from an immunology point of view, whether BCG has any positive protective.
It's a bit complex and very complicated story. I read most of the papers that were published, and none of them is convincing.
Yeah.
And you know, in the 70s, they used to give the BCG as a vaccination for all women who had breast cancer, and they give the BCG as a tool to stimulate cellular immunity. And by the way, I have severe allergy and asthma, and because I have severe allergy and asthma, this means I have a type 2 hypersensitivity, not type 2 hypersensitivity reaction, but Th2 response, which is mediated usually my immune system is biased towards Th2 response. And when I get the BCG vaccine, usually I get a switch to Th1 for 3 or 4 months. And I get improvement in my allergy because I'm just immunomodulating my immune response. And I do believe that vaccination with BCG might improve the immunity and can modulate your immune response. This is just from a very basic immunology background, but there is no evidence at all to support, evidence on hand from a lab but all of them, they were observational studies that BCG, those who were vaccinated with BCG, usually they have mild disease or they have get low incidence of disease. And the data are not convincing at all.
Thank you very much. Thank you very much. Finally, I just want to say once again, thank you to all three of us speakers, Dr. Afroz, Dr. Ghazali, Dr. Leila. Thank you very much for very illuminating, very fascinating talks. Also, I would like to take this opportunity to thank all the participants who took part in this today's webinar. The MCO will send a survey via email. Please make sure to complete this survey to receive your CME certificate. Once again, thank you very much. Take care, everybody. Take care.
Oh, thank you very much.
Bye-bye. Bye-bye. Take care.
Thank you.